Today's learning session serves as the official program kickoff, but please note there is still time to get enrolled into the program. We want to thank our program partners, the Ohio Department of Health, specifically the Violence and Injury Prevention Section, or VIPS. Today's agenda, we want to welcome everyone for coming. We want to go through introductions. We have some Zoom polls, some presentations, and a reminder of next steps for the program. Okay, if you don't mind, if you could please share in the chat your name, your role, your organization, and what county you are practicing in. To introduce our team, my name is Brooke Powell. I'm the program manager for the Injury Prevention plus Seek QI program. I will be your contact for all things program related. We also work with our wonderful data analyst, Zainab. She will be helping us with the data throughout this program. And the two medical directors that we have the pleasure of working with throughout this program are presenting today, and you will hear from them. Dr. Mike Gittleman is a pediatric emergency room physician at Cincinnati Children's Hospital in Cincinnati, Ohio. He's also a professor of clinical pediatrics at the University of Cincinnati School of Medicine. Prior to their formation of a council, he served as the chairperson for the American Academy of Pediatrics section on injury, violence, and poison prevention. He is currently the District 5 Vice Chair for the AAP. With the Ohio AAP, he has developed statewide bicycle helmet intervention, a gun safety program in the pediatric office setting, a hospital-based safe sleep QI program, an injury QI program for participating pediatricians, and lethal means safe storage program that includes youth suicide prevention. Also sharing today is Dr. Sarah Denny. She works as an attending physician in the Division of Pediatric Primary Care at Nationwide Children's Hospital and is an associate professor of pediatrics at The Ohio State University School of Medicine. She's a co-chair of the Injury, Violence, and Poison Prevention for the Ohio chapter of the American Academy of Pediatrics. And at the national level, she served as on the executive committee for the Council on Injury, Violence, and Poison Prevention for the American Academy of Pediatrics and was a lead author on the Prevention of Drowning Policy Statement, which was published last year. Dr. Denny sits on the board of directors as treasurer for the Ohio AAP and is the co-chair of the chapter advocacy committee. Okay, I'm going to launch two different sets of Zoom polls. You'll have a minute on each to answer these. And then if you have any reaction or anything that strikes you as interesting on these answers, please share in the chat. The first Zoom poll has to do with the topics that we will be covering in this program around social determinants of health. And as you are coming in and as you are completing the poll, if you didn't hear this at the beginning, if you could please in the chat, leave your name, role, institution, and county you are practicing in, please. I'm going to launch the second poll. This is around the injury prevention topics that are covered within this program. Thank you for your participation for those. I'm going to share the results of the social determinants poll. If there is quite the variety shared here of topics of the greatest need of your patients and families. I think we expected the data to be distributed this way. We know that this reflects the importance of all of these topics that we will be covering. We have a higher percentage under the results of the second question. Maybe it's easier to discuss maternal depression or parenting skills in the office, but that doesn't mean there isn't potential for more discussion, which this program will help you with. Does the high percentage of job resources selected for the third question, does anyone find this very interesting? Okay, results of injury. Greatest needs for injury, car seat safety. I think we knew that one. Home safety, safe sleep. That's a big one. Smoking in the home. Car seat safety is talked about. Safe sleep. I think it's promising that smoke and carbon monoxide alarms are more easily accessible than maybe another resource for our patients and families. So seeing that in the top three makes me hopeful that we can address that for sure. Okay, thank you guys so much for sharing those. What makes Wave 4 different for Injury Prevention Plus Seek program? First of all, I want to thank all of you for participating in this. It means your enrollment means that you know how important this work is to your patients and families. The new focus this wave is on populations in target counties. So the state of Ohio ODH took a look at the data in the counties and identified counties that have a greater need for social determinants of health programs. They are starred in blue. A lot of you are practicing in these counties, you live in these counties, or you live in a border county, which were also included in this program. So they wanted to target that to help the patients and families with the greatest need. And now, Dr. Gittleman, I'm going to hand it off to you.
Great. Can you hear me, Brooke?
I can. Thank you.
Okay, perfect. I get to talk a little bit about social determinants of health and injury and a little bit about this program. And so over the next 15 minutes, I'm giving a lot of background. And if you have questions or anything you want to say, put it into the chat box and we can respond towards the end. Next slide. I have nothing to disclose. I do always thank the Ohio chapter for all of the work that they do for pediatricians in the state, as well as the Ohio Department of Health for funding of our program. Next slide. So I'm going to start with a case, and the case, it's a true case. And so that's why I find it most unfortunate. But, and you could imagine how this could happen to really any pediatrician. So a newborn comes into your office at 2 weeks of life. It's a full-term birth, no complications. And then after the 2-week visit, they did not come back for another visit. Next slide. Next thing, I work in an emergency department. EMS presents to the home of now a 3-month-old. The patient's found in mom's bed, pulseless, unresponsive. Upon arrival, EMS starts CPR. They did about 30 minutes of CPR. They got no spontaneous circulation, and the child was pronounced dead in our emergency department. Next slide. So it's interesting, when we went back and looked at this case, this family lived less than a mile from the children's hospital. They had barriers to getting to their appointment. It's not that they didn't want to go. They wanted to go for their follow-up appointments. They had a hard time. They had no transportation. The parents' work schedule was changing all the time. And so they had a difficult time getting in on an appointment in a regular basis. And then one thing led to another, and they kind of forgotten, and they just went and they never made that follow-up appointment. When they look back, there was no counseling about safe sleep at the 2-week visit, and the family had no money to purchase a crib, and so that's why the baby was sleeping in bed with them. Next slide. So when we talk about social determinants of health, we're looking at necessary resources like food, housing, economic, social relationships, transportation, education, whose distribution across populations determines length and quality of life, right? And so when we're talking about social determinants of health, I want you guys to think about this, that, we sit there and through our training, I just gave a talk this morning to residents, and through our training, we hear about, infectious disease problems, but a lot of the time we're not learning about what are these other problems, and these determine the health of our families. If they can have transportation, if they aren't educated, if they have no funding, if they can't get food, these are major problems that affects the children's health. And how do we help with the families is something that we should be looking at. Next slide. So today we're going to talk a little bit about, as I said, social determinants of health and pediatric injuries, kind of learn a little bit about what we're going to be asked to do over the next couple months of incorporating it into practice. And we'll show you a little bit about some of the resources that we have available. Next slide. So Abraham Jacobi, like the founding father of the American Academy of Pediatrics, he said a long time ago, it's not enough to work at the individual bedside in the hospital. In the near dim future, the pediatrician's going to sit in and control school boards, health departments, and legislatures, because it's the pediatrician that knows what's going on in the community. And really, it's more than just taking care of them in the office. What else can we do as pediatricians? Next slide. And then when you talk to families, their perspective is, look, my window's broken, there are roaches, my landlord isn't responsive at all. Now, keep going. And you hit one more. And so you talk to families and they have these struggles. We sit there and we write a prescription and say, go to the pharmacy and you can get it. Well, they can't get to the pharmacy. It might take 4 hours for them to get there. They don't have the money for the medication. I mean, it's those kind of things that make it very difficult on families. And once they leave our office, how else can we help them is something that we need to think about. Next slide. And you can scroll through a couple of these. So what I want you to think about is that often we talk about equality. Right? So equality is, if you take a look, here, you keep going, Brooke. One more. So equality is the concept where, and what we always think about is, or that everybody's getting the same thing. So if you take a look at equality in the picture, right, all the boxes are the same. However, because the fence is different, that there's disparities, which should not exist. And so in reality, what we try and do is we try and put in equal care. And we have the boxes all the same, but the disparities make it so that it's really not equitable. And what we want to start thinking about is, how do we have equitable care where we arrange the box for the family based on that fence setting? So some need a greater box than others, but then what that does is it gives justice where everybody's now equal to be able to, succeed and be the healthiest they can for their families. Next slide. And there's examples of health inequities, in our populations. So African-American mothers with a high school education are 2.2 times more likely to have infant death in the first year of life. Or lower socioeconomic families is more associated with an increased risk of main diseases like heart disease, arthritis, diabetes. And access to resources. So if you're lower socioeconomic family, that you're less likely to have access to grocery stores, fruits, vegetables. So there are health inequities amongst the populations of patients that we care for on a day-to-day basis. Next slide. And so what are the causes for these lower health equity? Well, the social environment that they live in. So they might not have social capita, or there might be discrimination in the communities they live. Next. The economic environment. So, they might have a lower socioeconomic status, or they might be living in poverty, making it harder for them to be able to care for the health of their children. And next. And it could be their physical environment, right? So there's families that still live, especially like in the Cleveland area, that still have lead-based paint that their kids are exposed to, where they might have mold or roaches, or in the outdoor environment that there's really no play structures for them to play in. So they're playing in streets and, they're at greater risk. Next slide. And so these are what most look at in social determinants of health. And we're talking about access to healthcare, access to resources like food, legal care, education, employment, environment, income and poverty, insurance coverage, housing, racism, segregation, and transportation. So we look at, social determinants of health. These are kind of the broad spectrum areas that we try and take a look at. Next slide. And what we want to start moving towards is, how do we get action on these social determinants of health, right? And so how do we know a family needs help with housing? How do we know if that family is having a problem with transportation? Just like in the case that I presented, the family came in at their 2-week visit, they didn't come back, and we just thought, lost to follow-up, but they actually had some other problems, such as they didn't have transportation. They had a hard time getting to their office appointment. They had a hard time with the scheduling. And how do we get to know that as a practitioner? And what kind of interventions can we put into place to affect it? So we find out that they have a problem with transportation. Well, is there maybe a telemedicine option? Or is there maybe a phone tree option that we can help them at? And many of these interventions can be started by the primary care physician when they're seeing the patient. Next slide. And you can hit a couple of the things because they go through, but what we want to do is figure out the risk assessment. So common asks at the office visit. And then once we figured out that risk, by putting in a hierarchy, how do we address them and get them to the resources that they need? So they come in and they say, I can't afford a crib, but I understand what you're saying and I need one. Okay, well, what resources available for them to get a crib so that we can help that family out? Next slide. And then we've spent some time talking about the social determinants of health. Well, what's interesting is injuries are also the leading cause of death. These same families have injury risks just as they do other social risks. And, injuries cause more deaths than all diseases combined. And if we can address them in the office setting, we can actually change their behaviors and make families healthier. And that's kind of why our program came about, which is, if we're going to address some of these social needs, let's also address the number one cause of death to kids, which is injuries. Next slide. So we are in, I believe it's the 4th wave of our Seek injury. So it's a kind of a well-oiled machine that you are getting involved in. But I will show you some data that Dr. Denny, who you're going to hear from next, kind of put this data together and actually published this in a peer-reviewed journal. Next slide. So our injury collaborative, a while back, unfortunately, way too many years back, Dr. Denny and the Ohio chapter and myself, we did an injury screening tool. Next slide. And then, as I mentioned, that we merged our injury screening tool with what was called the Seek program. And the Seek problem looked a lot more at some of these social determinants and had some injury questions. So we developed this tool using a lot of the Seek questions and then a lot of our experience of injury prevention questions. Next slide. And then what we did was we put it into practice. We had 2 waves, and similar to what you're going to have, we got participants got MOC credit for participating. And then what we did was we looked at and we followed up to see what risks did we uncover. Next slide. And if you take a look, and you'll get all of this in your packet, but when we're looking at kids 0 to 5, we're addressing all of these problems for families: substance abuse, maternal depression, child safety. We're looking at unintentional injuries, and then we're providing resources once we determine there's a risk. And then once those resources are put into place, now families can actually make decisions to make their kids safer and or get the social needs that they are at risk for once they leave your office setting. Next slide. So with this QI program, and I'm describing, which is what we're doing now, is, they had pre-work calls like you all did, the one-day learning session, which you're having now, and then the monthly action period calls, which you're going to be having after this on a monthly basis. And then you have to put PDSAs into practice to make sure that you're using the tools consistently. And I'm sure you're going to hear more about this, but the more that there is consistency of your daily practice and getting it in there, so the office staff is doing all the work, it's done every time, you'll be more consistent in getting this in place. And if you're consistently putting it in place, you're going to be helping your families more consistently. Next slide. So we collected data just as you all provided some baseline data, and then we did monthly chart reviews, and then we analyzed this over the course of the 2 waves. Next slide. What we found, and this is in Dr. Denny's paper, but what we found was the good amount of the families had Medicaid insurance. And as you can see, there were all types of practices. Some were urban, some were rural, some were suburban, some were larger, some were smaller, but they all had very similar, patient populations. Next slide. And what we found was in the birth to 1 year at baseline, when we reviewed 68 charts, we found 31% of SEEK IP topics were addressed. So the majority of the time, the practitioners were not addressing SEEK or injury topics. When we looked at the action periods and we reviewed on average, there were about 4 or 5 risks identified on charts. And so, I know that there's always apprehension of, boy, this is something that I don't know if I'm comfortable discussing. Well, that's why you have all of our resources to help you with that. And you might say, well, I'm not sure what resources are available. That's why we've provided you with all these resources. And you might say, well, I'm going to be talking more. Well, actually, you're really talking less, because instead of feeling like you have to address 20 topics, you're actually addressing maybe 4 topics, because you realize on average, families only have about 4 or 5 risk topics, and then you can actually gear it towards that. If you can't get through all of them, at least you can start and say, I'm going to get through at least 2, or I'm going to get through at least 3, so that you can actually get it into place. And by the end of the collaborative, what was really interesting in the birth to 1 year, we found that inappropriate responses were counseled about 83% of the time, which was an increase of by 50%, or from 50% at baseline, and 63% of resources were provided to families when appropriate. So because of using the tool, you assessed the risk and resources were available, and you provided resources. Next slide. And we found very similar findings in the 1 to 5 year. Only about 25% at baseline were being addressed. And during the action period, about 4 or 5 risks were identified, and about 70% of resources were provided to families that were appropriate by the end of the program. Next slide. And what we found, which was interesting, was there were many more injury risks that were found than social risks. So it's important for us to elicit these so that we can actually make a change, because, God forbid, as I showed in the case, that there was a significant injury risk that they were sleeping with the child, but there were also those social risks that made it so that they wouldn't change their behaviors readily. And that's why it's important for us to assess that, elicit that, to be able to make that change, so we don't have these catastrophic problems in the back end. Next slide. So hopefully you've gotten to see why it's important that we address some of these social determinants of health and injury risks, that this program streamlines it and makes it very easy and simple for us, as long as we get it into practice. And then we can actually make changes of families' behavior by putting it into place. Next slide. And with that, I will turn it over to Dr. Denny.
Great. Thank you so much, Mike. So hello, thank you guys all for joining us today. I am currently in primary care. I've been in primary care for the last 3 years. Prior to that, I spent 12 years in the emergency department. So have tons of experience on the injury side in the ER, and now I'm spending much more time on the prevention side during anticipatory guidance. So it's been an awesome journey. I think one of the things we know about is that we, as healthcare providers in general, I should say, are less likely to talk about topics during our anticipatory guidance if we are less comfortable or have less knowledge in those. And so obviously talking to families about things like food insecurity and things related to their parenting styles and that kind of thing can be a little bit sensitive. So what we're going to talk about today is how, first of all, obviously from what Mike just said, talking about these issues is really important. They all affect health outcomes, but how can we do it in a way that is sensitive, but still getting the information we need and then providing support to the families based on where they are and what their needs are. So we're going to spend a little bit of time talking about that today. Next slide. So I think, one of the things that is helpful to know is why do families come in for well childcare? Obviously, like vaccines is one, but this is from a study published in Pediatrics where they did surveys of families and wanted to know, like, what do you want from us? There's so many things Bright Futures recommends that we do that clearly we don't have time to do. So what is it that the families want? And this was a really good way to bring the family voice into this. And what they said is the main reasons why they come into the healthcare provider is number one, reassurance, just that they're doing a good job and that their kid is healthy and developing well. And then the second is to discuss their priorities. One of the things they mentioned, there's a lot of quotes from the survey results, and a lot of it is, they don't want to talk about X, Y, and Z if X, Y, and Z aren't a problem for their child. They want to talk about A, B, and C because A, B, and C are a problem for their child. And so that's one of the great things about this screening tool that you're going to be implementing is that it really does help you narrow down what is important to this family that is sitting in the exam room with you today. So you don't waste your time and the family's time talking about tons of stuff that really isn't relevant to their situation. But if they're about to lose their housing, guess what? None of the other stuff you're talking about is relevant to them because all they know is they're about to be on the street with their kid. And so what can we do in that moment? And how can we open up that kind of therapeutic alliance with the family to have those conversations and know that this is a safe space and we are here to help you. Now, I also teach residents a lot, and I also know that sometimes, we ask all these questions about housing and jobs and childcare and food insecurity and injury, and sometimes the information we get back can be overwhelming. And so I think the thing that I teach them a lot is we don't have to fix all of this, right? Like we don't have to fix all this in this exam room today, but we can, number one, show that we care about these things. Number two, provide some resources. And number three, it helps inform us as professionals about how we can advocate for system level change to help support the health outcomes and the system level issues that our families are facing. Next slide, please. One of the points that came up in the survey was around having a consistent physician, and the families that were surveyed said obviously promotes efficiency. Like if you know the family, it allows you to more efficiently kind of discuss their situation. It also enhances communication and enhances child comfort. Next slide. Along those lines of consistent provider, one of the notes that was also made in that survey result was that even being in a group where there's multiple providers and they see the same few, some really like that too, because they still felt like they were known, but it also gave them the opportunity to maybe like get a second opinion or feel comfortable with a couple of providers. So it doesn't necessarily always have to be the exact same physician taking care of that patient or same provider, but it is helpful to have, like not 30. But one of the things that they ask the families is, what do you think as a patient caregiver is the key elements of the physician-child relationship? And one was an emphasis on the child. So speaking to the child, respect for parental expertise. And I think we all got taught this in med school about parents being the expert on their child and you listen when the mom has a concern. And so that was just reiterated in this study. And then the affect and body language of the physician. And I think that's really critical when we're talking about some of these more sensitive issues is, having a very non-judgmental affect, having a body language that says that you're empathetic, that you're ready to listen, that kind of thing. Next slide. And then they made these recommendations for enhancements, and this was published in 2009. So I think it's a little bit dated because I think a lot of practices have evolved with technology, but they talked about using pre-visit materials and checklists to facilitate better use of time. I think that's super practice dependent. I have a significant, almost 100% Medicaid population with very low English literacy levels. So for me, pre-visit materials and checklists really aren't something that's going to help facilitate improved time. But it may be different. Every practice is different. Every patient population is different. Using wait times as an opportunity to provide information, whether that's through digital signage, whether it's things for them to read on an iPad. Seminars and workshops led by pediatricians on child health. I know some of you do kind of centering education, which I think is really nice because it provides kind of that more seminar or workshop opportunity for families to not only learn about parenting, which as on your survey, we all saw that was a tremendous need, but also allows them to link with other parents having similar challenges. And then better linkage with community resources, which is something that we're trying to do through this learning collaborative. Next slide. Okay, and then they said, I'm sure we all could come up with a number of areas for improvement, but some of the survey respondents said better marketing about the value of well childcare. I know that's something that I struggle a lot with is why do we ask families to bring their kids to the doctor when they're well? And then a lot of times families were saying they'd like to know kind of what the schedule is, and then notification reminders. Again, this is a little bit dated. I think that this information is stuff that we're probably doing, but increased emphasis on development and behavior. When we go back to those original things about, why are parents bringing their children in, it's because they want reassurance and they want to know about growth and development and behavior. And then enhanced information exchange. Next slide. This is a really, really interesting study, and I'm going to talk about it today, but I'm actually going to also talk about another part of the same study in our action period call in a couple weeks. But this was done in focus groups where they asked focus groups of parents in 3 different parts of the country, and then a focus group of pediatricians about some certain AAP policy statements and around corporal punishment and gun safety. And then they asked parents to give them, they had some scripted questions. And so I think it's really helpful to kind of talk through some of the findings, because part of what we're talking about in this learning collaborative is around like parenting and gun safety and restriction of lethal means. So one of the things they talked about is maybe not necessarily understanding why as healthcare providers, we would even be asking these questions. And so, one of the things in our Store It Safe learning collaborative is really, rolling it into the safety part of our talk. Like this is, I'm talking about child passenger safety. I'm talking about gun safety. I'm talking about poison control, making that part of it so that it does kind of make sense as to why. Pediatricians' attitude, I think that this is true in anything, how we convey messages or ask questions in a non-judgmental way really affects how the family receives our message. And then they also offered some advice concerning ways to communicate. Next slide. So around gun safety, the parents said, physicians really need to understand that gun ownership is normative in many communities, and that they felt like telling a family to get rid of their gun was not an effective way to communicate gun safety. And the other key point that they pointed out was that parents within a family may not necessarily agree on the issue. And just that providers need to be sensitive to that, but that even if parents in a family don't agree on the issue, they still appreciate the provider bringing it up and kind of acting a little bit as a moderator of that discussion. Next slide. So this is very similar to what we found in our own gun safety work. They don't want record of the gun ownership, so not documented in the EMR. Some people suggest offering gun safety information without asking about ownership. Again, talking in a non-condescending, non-judgmental way, providing some written materials in addition to talking. And then they asked about statistics and whether or not they found sharing statistics with the families as helpful. And it was kind of a mixed result. Next slide. Now, in the pediatrician focus groups, and I think that none of this is going to be new or earth-shattering to anyone on this call. it's difficult to strike that balance between what the family wants to talk about and what we feel like we need to talk about. And several of the focus group respondents said that they found it helpful on the more difficult topics, especially around gun storage, to use news stories or personal experience to kind of tie in. I've been doing that a lot recently. We've had multiple drownings here in Columbus, and also many safe sleep deaths. So I'm kind of pulling those in to show the relevance in the exam room when I'm talking about anticipatory guidance. And then, as I kind of started off, we received such little training in these areas that we feel not as well prepared as we could be to have these discussions. And then sometimes prioritizing issues is challenging. Next slide. And in both policy statements that were presented to these focus groups, the pediatrician focus group really felt like the policies were at odds with social norms of many patient populations. And then there was a lot of concern around talking about corporal punishments while we're also mandated reporters. Next slide. So we agree, both parents and healthcare providers agree that there are difficult topics, but just know that the families really do appreciate us talking about these things. Next slide. Okay, so we know that it's part of kind of our anticipatory guidance, and we know that it's important to discuss, but really why is it? Next slide. I'm assuming that everyone on the call knows what an ACE is, an adverse childhood event. The ACEs study was done in the Kaiser Permanente health systems and looked at these are the studied ACEs in that particular study. So abuse, physical, emotional, and sexual abuse, neglect, physical and emotional neglect, and then household dysfunction, which they categorized as mental illness, an incarcerated relative, a mother treated violently, substance abuse, or divorce. Now, this is not part of our history taking, but these are incredibly important when we're looking at health outcomes. So, this goes towards kind of that whole discussion about really learning about what's going on with a family and figuring out how we can help support families to maximize health outcomes for the kids. Next slide. This is a super brief summary because I figured most everyone knows about ACEs, but we know from the work done on ACEs that there is epigenetic changes that occur. So at the very basic biological level, there are changes to the architecture of the brain, which then affects the child's health and development. And so there's this kind of vicious cycle that goes on as demonstrated with this infographic. Next slide. I use this with the residents all the time because I think it's such a great picture of the cellular level. At the bottom, you can see a neuron, which has been a child who's been exposed to toxic stress. You can see how far fewer the dendritic connections are than a normal neuron of a child who's not been experiencing chronic toxic stress. So again, those ACEs are what causes the toxic stress, which cause the cellular changes that then go on to change how a child's able to develop and interact. Next slide. This is just a small sample of the way early adversity affects health outcomes, whether it's related to injury and unexpected pregnancy, preterm delivery, cancer, diabetes, and even like education and occupational opportunities as they grow older. What's important to remember about the ACEs study is that I think you could easily fall into the mindset where you're like, well, yes, if a person is brought up in a really stressful environment, they may then be more likely to make bad choices. When the researchers did this study, they accounted for that and they took those variables out. And even if you made like the most amazing choices and had the best possible, path out of a difficult childhood, you are still at risk of these issues, whether it's mental health or physical health related. Next slide. When it comes down to life expectancy, ACEs really matter. I would very much encourage you to look at the life expectancy for where your clinic is located, and then look at the life expectancy for where you live and see how different it is. Where I live compared to the hospital, it's over a decade difference, and we are less than 6 miles apart. So zip code matters for all those reasons that Mike just talked about around housing and that kind of stuff. And that really speaks to our role as providers, as how we need to be involved in our community and with our policymakers as well. Next slide. Okay, and then the other piece, and this is something we never want to think about related to our patient population, but we have to think about it. So child abuse and neglect. In 2020, 1,750 children died in the US of abuse and neglect. And we know that the kids younger than 3 make up the majority of those fatalities, with the first year of life as the highest rate of victimization. So again, screening for those risk factors is really important. Next slide. This is just demonstrates what I just said about kind of those high risk ages, but you can see definitely 3 and under as really your highest risk age groups. Next slide. I thought it would be helpful to look at Ohio specific data. These are the rate or the number of deaths from 2015 to 2019. And again, you can look more specifically at your county level data, which might help inform kind of where you want to focus your attention on injury fatalities in general. But you can see kind of the age breakdown very much mirrors the national data. And then racial breakdown. There's a lot more data available from the Ohio Child Fatality Review if you're interested in doing a deeper dive, but I just wanted to include a few slides here. Next slide. And then who is often the person responsible for child abuse and neglect? The biological parent or the mother or father's partner make up the largest percentage of abusers. Next slide. And this just breaks down the actual causes. Next slide. But when we're talking about ACEs and we're talking about strategies to reduce child abuse, there are a lot of evidence-based strategies to reduce this. We know that things that promote resilience are really great at help mitigating the effects of ACEs. And so things like that would be high quality early education, relationships with a trusted adult who is a positive influence on their life. And that doesn't necessarily mean it's a caregiver. Maybe it's a big brothers, big sisters mentorship program. Maybe it's someone at their place of worship or a coach. So just trying to kind of identify some of those people in your patient's lives can be very helpful. Nurse family partnerships is been shown to improve resiliency and also to reduce child abuse. So this is a program that we all have access to, and it can it has patients or nurses, I'm sorry, that go into the home and really provide a lot of assistance to first-time moms around parenting, around health, and can really help troubleshoot and link with resources. Triple P parenting, you guys all responded that parenting is one of the biggest things that we're talking about. There is now available to families in Ohio free Triple P parenting available online, so they don't have to go to a class. I put the link in here for you. I think especially families or parents who come from a really chaotic childhood want to do the right thing, but don't know how. They've not had that modeled for them. I had a young mom come in just the other day, and she's like, my friends keep telling me I need to put my kids on a schedule, but I don't even know what that means or how to do it. And so we just kind of talked through, what does that look? Okay, and Tracy says we use Triple P and it's wonderful. Absolutely. So yeah, this funding ODJFS in Ohio. Oh, can you go back, please? Yeah, Ohio Children's Task Force or Ohio Children's Trust Fund share that. So yes, a huge recommendation for that. And I believe there may be more than one language available, but yes, great, just general parenting strategies. And I know when I was a resident, I was not a parent. And so I felt like every single family wanted to talk about parenting, breastfeeding, and infant sleep. And I felt like I knew nothing about any of those 3 things. So this is a really nice resource for families. And then the Healthy Start Program Enhanced Model is another evidence-based strategy that combines both those home-based services that we see in our visiting nurse family partnerships, as well as cognitive behavioral treatment. So I put a link on here where you can look up what is available in your area. So again, these are evidence-based strategies. They build resiliency. They improve that parent-child relationship that is protective as well. And so I would just encourage you to identify these resources in your community. Next slide. Okay, so I put, I put the resources here that I used for this talk, including links to the studies that I referenced, as well as some of the like that child fatality review report that is available. And again, you know, looking at your county level data really might guide kind of what you want to focus on. I am kind of a fan of, we don't have to necessarily be experts on every single thing, but we should be experts on what's going to kill our patients. And we need to really talk about that in our offices. And, you know, maybe that is based on the data in your area. Maybe that's based on the needs of your family. Maybe that's based, you know, it obviously changes by age group. So we have the like 0 to 1 and what are they most at risk of getting injured or dying from? And then we have the 1 to 5 for the purposes of this particular learning collaborative. And so what are the biggest causes of death or injury in those groups? And so how do we focus our energies and our talking appropriately? So that's all I have for my section. I'm happy to answer any questions if you have them.
Thank you so much, Dr. Denny, Dr. Gittimer, for that wonderful information. Yes, if anybody has any questions for either of our medical directors, you can unmute to talk about it. You can put it in the chat, but if you think of something later, you can always email me with it. We will be distributing this information as well as a recording of this session for your review. And I wanted to launch our last Zoom poll. Please hold. Okay, it's going to gauge your readiness to start the program, given all the pre-work you have done and the good information that you learned today from the learning session. And I just also during this time wanted to review, while you guys are thinking of questions for our medical directors and answering the poll, what to do when your box of program materials arrives. So the first thing you want to do is charge those iPads. We will be submitting enclosing some instructions that for your review along the lines of using the iPads, and then begin testing the Seek screening tool, which is embedded into the iPad. Next steps for the fully enrolled participants, or for those of you who aren't quite fully enrolled but just wanted to learn more today, I will certainly send you more information. So if you haven't done so already, view the pre-work webinar recording, complete the pre-work survey, complete the baseline data survey, and then if you don't mind scheduling with me your first practice coaching call with me. And then at the end of August is also do your first PDSA cycle. Okay, and just a reminder to mark your calendars. The data submissions for the pre-work and baseline is due this Friday, the 12th. If you need more time, I completely understand, and we can talk through that. The action period call, the first one, that's going to be featuring Dr. Denny, is Wednesday, the 24th. If you don't already have a calendar invite, I will certainly send you one. And the first PDSA cycle is due by Wednesday, August 31st. And we are back to questions. If you thought of any questions about the program in general or the good content that we had today, you can share it now. Okay, hearing none. we can give you a few minutes back of your day, but I will be in touch with you regarding more program information. But please don't hesitate to reach out if you have any questions. Thank you so much. Have a great day.